Hi, this is Stephen Dell, and my topic is lifestyle history, what's important, and how to elicit it. And these are my financial disclosures. So, who are these patients that are candidates for IOLs? If you could see through my little image there on the upper right, you'd see that this group of individuals is increasing in size very rapidly, and we know that they're much more active than their predecessors. And in the past, picking an IOL was pretty simple because we put the same lens in everybody. But that's really not true any longer because now we have a whole spectrum of different lenses where we have monofocals all the way up to high ad multifocals. And as we move to the right on this chart, we get more visual photic phenomenon, but we also get better near. And we can debate where these terms belong on this particular graph, but the concept is valid that as we get more near vision, we have to put up with more night vision complaints. And there's a fairly dizzying array of choices now where we can put the same implant in each eye or we can mix these lenses. And now that we have the availability of trifocals and light adjustable lenses, along with EDOF lenses and various other multifocal and accommodating lenses, there's a very large array of choice here for any given patient. Those of us who use presbyopia correcting IOLs know that there is a seasonality to night vision complaints that you get from patients. And you observe this over the years because you figure out that 7 p.m. in the summer is very different than 7 p.m. in the winter. And by the same token, there's a seasonality to what we're dealing with right now. We are right now in the COVID-19 season, but this season is not going to last forever. But I would suggest that there will be in some enduring societal changes that we will see after this pandemic is over. And many of these changes and trends predate the pandemic, but they were accelerated by it. So when we ask our patient what their daily activities look like, they tell us that they start their day out with Google and they move on to Instagram and maybe spend some time on Amazon and then Instacart for dinner and then Netflix in the evening. But this is really reflective of a larger trend where, for example, a lot of our patients are not spending as much time driving. And the rise of autonomous vehicles is something that has been going on for several years. There are 5 levels of autonomous driving technology, from 0 automation all the way up to 5, which are fully autonomous capable vehicles. And these manufacturers have stated that they will reach their goal of level 5 autonomous driving next year. Now, another interesting trend is if you look at cinema attendance over the last 20 years, it used to be that people went to the movies about 5 times a year on average. That had declined to 3.5 times a year in 2018. And last quarter, it went to 0. Now, I don't think anyone expects that the North American cinema industry is going to recover to levels previously seen anytime soon. But on the other hand, Netflix usage, Netflix worldwide subscribers numbers have grown significantly, and that trend of growth has accelerated in the last year. And this is part of an inexorable overall change in human visual demands, where we've gone from hunter-gatherers who needed great distance vision to tradesmen and the importance of desk work. And this has just been a part of a long-term societal shift. And so we developed years ago a questionnaire to try to figure out who wanted to see where when we were trying to figure out a lens that we would use for any given patient. And this questionnaire asks some basic questions of patients like, where do you want to see without glasses? And how critical is your night vision? And where is your habitual near working distance? Would you be open to some optical compromise to achieve that? Would you be willing to pay for that? How much of a perfectionist do you consider yourself to be? And we've modified this questionnaire over the years, but it's a really good starting point to try to figure out what your patient wants quickly and to establish some common goals. And you can download this and modify it for your own use as you see fit. But the effect of this questionnaire is that it establishes very quickly a common vocabulary and forces patients to make some prioritized visual choices. The patients figure out that they have to make some compromises. It also figures out which of our patients have no interest in spectacle independence or who don't understand the concepts that we're trying to present. And you can sometimes uncover some unusual visual requests. But the real secret is that it lowers patient expectations, and it's a good starting point for a discussion. Because some of our patients have different ideas in their mind about what distance vision is. It might be TV, it might be looking off at infinity. And by the same token, they have different ideas of what we mean when we say near vision or intermediate vision or computer vision. Those are different things to different people, and it's important to figure that out. Once we sort out what our patient wants, then it's our job to figure out if there are ocular contraindications to using these technologies. And then we have to accurately and honestly disclose the pros and the cons to our patients and exclude those who have unrealistic expectations. It's very important not to pressure patients, and we always want to underpromise. But the reality is that a larger percentage of our patients are now premium IOL candidates because we have toric versions of multifocals, EDOF lenses, monofocals, and now light adjustable lenses. And some of the hard lessons that I've learned over the years are that you eliminate natural monovision at your peril, and that nothing we have beats the near sight of nearsightedness. And sometimes patients come to us who are retired, but maybe they spent 30 years in an occupation that was very visually demanding. Also keep in mind that neuroadaptation is real, but so is neuroresignation, where the patient just gets tired of complaining about a problem and you get sick of listening to it. And also, I think it's useful to keep in mind this phenomenon of new lens euphoria, where we get very excited about a new technology, and so we use it in anyone who will accept it. Ultimately, we learn which patients are poor candidates for that technology, and we dial back our use of that technology to more appropriate levels of patient use. So I hope you will keep these concepts in mind as you're selecting lenses for your patients. Thank you very much.
Hi, I'm John Hovannessian. Let's talk about psychometrics and patient selection for cataract surgery. I have a number of financial interests, including an MD backline that we'll be talking about. Today, we surgeons have a number of wonderful premium IOLs, including torics that give great distance vision and monovision, and presbyopia correcting lenses that can give a full range of vision. And we know from a number of studies, including one we did that looked at 5 to 10 year outcomes, that the vast majority of patients not only are very happy, but stable with their satisfaction, even with the earlier generation lenses, when those patients are well selected. Now, there are a number of ways we can stumble in patient selection and make terrible mistakes. One easy way is if we ignore biometrics. That's the science of looking at higher order aberrations and cord mu, looking at the ocular surface and looking at the macula. We have a pretty good science and ability to know what trouble to avoid there, but what about psychometrics? Wouldn't it be nice if we could look at the face of the patient and identify what their personality was like? Unfortunately, most of our patients don't come with signs hanging on them telling us what they're like. And in fact, we're very busy people, and we have very little time to see each patient in a week of seeing patients. And we have an awful lot to do in each of those 10-minute periods, including get to know the patient, establishing trust, documenting their needs, diagnosing and coming up with a solution, communicating it, and so forth. And the truth is, there's just not time with every patient for learning what they're all about and what solution might be suitable to them, including whether they're interested in having a premium lens in the first place. Well, psychometrics is the science designed to help us. It's defined as the science of measuring mental capacities and processes, but when applied to premium lenses, it can help us understand what type of patient will likely do well with presbyopia correction, who is really interested, and what technologies might be best suited to them. Now, to make this easier, we're using a software called MD Backline that's designed as a web service that automates conversations with patients both before and after office visits to find out what their patient lifestyle and their visual needs are, to give them educational material so they can learn about premium lenses before we even meet them, and to predict which patients are most likely to want and to do well with a premium lens. It also suggests which types of solutions might be suitable for each patient. It starts with a text message or email to each patient to ask them to complete an online questionnaire where they, through a very simple user interface written in 5th grade language, can answer questions that we pose to them. It comes directly from the doctor with the doctor's picture and name on it. And then it presents learning material that is specific to the answers that they have already given. So just as we counsel patients individually, so does MD Backline. It also gives patients a chance to read actual comments from earlier patients who had each type of lens. And this is very valuable because they love to see peer writings on what they thought of lenses. And it turns out most of these lenses earn about a 4.5-star rating. So like the most trusted Amazon products, premium lenses are popular with patients. It also gives us a one-page visual profile report. And here are some little sections from it, including one that tells us how severe the symptoms are of cataract, whether they're even ready for surgery, what type of vision they use mostly, how many different activities do they do, like driving at night or doing fine print, have they had contact lens experience with monovision or multifocals, how successful was it, previous surgery, and a number of other elements. It summarizes everything in a small box in the corner that tells us first, high, medium, or low, how likely is this patient to want and do well with a premium lens implant, and then it suggests which types of technologies might be suitable to that patient and whether there are cautions we should consider in proceeding. Now, patients really like it. They enjoy having this extra touch point with their doctor, so they're very happy to complete it. And in many practices, this is the pathway to see the doctor, and so 100% of patients participate. And it increases premium adoption. Here are 4 separate practices which were measured before and after MD Backline. And what we've seen is that most of our colleagues using the system have increased significantly, more than doubling their premium lens adoption. And the income implications of this are written after the lens implants are paid for. So in summary, we have a lot of different choices for lens technology that we can use, and most patients are interested. It's really helpful to pre-identify and pre-educate those patients who are most interested with a system like MD Backline to yield us more productive conversations, happier patients, and stronger practices. I'm John Hovnessian. Thanks for watching.
Great. Those are excellent topics and excellent talks. We're now going to have our panel discussions. We have about 10 minutes. We have with us Dr. Yuri McKee, Dr. Nathan Radcliffe, and then our 2 speakers, of course, Dr. Dylan Hovnessian. Thanks for those excellent talks, you guys. You know, I think this is such an interesting and important topic. When we look at premium IOLs, we know that lots of patients are interested, but I think something that sort of scares away a lot of clinicians is they don't feel like they have an efficient way to assess patients. So what are your, in your own practices, especially for those of you doing premium lenses, what was the most efficient pearl you can give to our audience today on kind of accomplishing some of these, understanding our patients better and their willingness to accept technology?
I'll jump in first on that one, Priya. One really valuable tip that I've learned over the years is that you can discern a whole lot about a patient by when they choose to present with visual complaints with a cataract. So there are patients who come to us who have 20/20 vision, tiny cataracts, and they're beside themselves with complaints. They really can't imagine how they can go on seeing as they do. That's a very different person than someone who comes in with a 20/60 cataract and really is there because their family is encouraging them to get the cataract removed because they're worried about their driving ability. So I think that when the person self-presents can be a very valuable indicator and an insight into their personality.
Great, Prof.
Yeah. And the flip side of that is, when have you seen a patient who's got a very dense cataract who complains about glare or halos with a multifocal lens after surgery? They just don't, because they're people who adjust.
Absolutely. Yuri, anything to
No,
add?
I show everybody, I have a little gummy lens that has the rings in it, and I shine a light through it onto a piece of paper, and several patients told me those are the rings I see. I have the multifocal. I show that to a prospective patient. If they recoil, I'm kind of done with the conversation. I'm not going to try to talk anyone into accepting those photic phenomenon. When somebody goes, yeah, that's fine, that wouldn't bother me, I really don't want to wear glasses, it really gives me a good fuzzy that we're down the right path with that type of person.
Nice. Nate,
I would also, yeah, Priya, I would also point out that it's useful to listen to your staff, because sometimes they're spending more time with these patients than you are. And if they give you an indication that there's something odd about a particular patient, I would ignore that at your peril, because that's very valuable insight. And they're often very nice and solicitous to us, but they can be rude and demeaning to our staff. And that's also a warning sign.
true colors.
My best technician used to be a waitress, and waitresses know people, and she picks up on stuff like that. She gave me a little wink, like, watch out for that one. Sometimes I'll walk into her office, say, I think this person's going to take a multifocal, and she'll say, no, they're not. So that's a very good point about your staff knowing people.
Yeah, I would say I switched from glaucoma mode, where I'm paying attention to data and all my reports. When I'm evaluating these patients, I really want them to talk open-ended questions, just let them sort of spill their guts a little bit and sort of see where they take me in terms of their personality. And it is always great when your surgical coordinator comes back to you after you send the patient and they say, are you sure you want to do that multifocal lens on this patient? And then maybe I'll go and talk to the patient a little bit more, and the conversation will go somewhere else. It's nice to have people who can steer you around your environment.
Definitely. For me, one of the things that's actually been really helpful is when I present the technologies, I just have like one sheet of paper and I kind of circle what I think is the best option for the patient. And when it comes to talking about a trifocal, multifocal, I'll often say, I don't offer this to everybody. And it sort of like sets this like, hey, wait, I want to know about this, and why can't everybody get this? And it just framing it in a way in which somebody has to like convince me that they're the right patient. I think it really allows that openness of that conversation. Or I'll say things like, generally, if you're an engineer or a type A person, I don't offer this to you. And then I sort of see what and I'll ask them, are you type A? You don't seem like you're type A, but are you? And it's just that like little bit of psychology. And for me, it's an efficient way, because I think that one of the things when you first get started with this technology is it seems overwhelming. Like, wait, I don't have 25 minutes to talk to every patient about this. And John, that's what I love about MD Backline is that to me is a very nicely efficient system. It's happening often outside the office as well.
Yeah, and I think that it's important to talk to virtually every patient about premium lenses, and even those who are not candidates deserve to know that they exist and that you don't recommend it. There's nothing sort of buys you greater credibility as a physician than to say, look, you could spend a bunch of money on this, but I don't think it's going to benefit you. Now, if you've got a family member who goes through cataract surgery, that may be a different thing. And it's just amazing how impactful that can be in setting up your relationship for success. Not just with the patient, but for others who they refer.
Completely agree. Yeah, go ahead.
Good comment there about telling people who aren't good candidates. I use myself as an example. I tell them, look, I'm a microsurgeon. I'm working within microns inside your eye while you're awake. And if everything is all the time, there's going to be problems about it when we're in surgery. So I'm in charge, and that's the end of it. And if that's your kind of personality, like I am, maybe you're not a great candidate for these multifocals.
Yeah, make it relatable. That's nice.
Yeah.
Absolutely.
Well said. What we want is as much information about the patient before we make a recommendation, and it does take some time to do. There's nothing like refining the conversation, but what we've tried to do with the questionnaire of MD Backline, which draws from the wisdom that Stephen has created for years for us with the Dell questionnaire, is to help get us to a place where we can kind of look at a corneal topography, an OCT of the macula, a visual profile report from MD Backline, and then know reasonably well what we might recommend to the patient.
One thing that I think is frustrating for many of us is that you can do everything correctly as a surgeon. You can assess the patient, you can ask all the right questions, you can make sure that cord mu is perfect, you can do all the testing that you want, and you can do flawless surgery, but there will be some small percentage of individuals who simply do not like the lens that you've put in. And that is an unavoidable consequence of using any presbyopia correcting technology. And for some surgeons, those few and far between patients are enough to dissuade them from ever using these technologies. So you have to be willing to accept that as part of the process. And once you are, and you have the tools in your toolbox to fix those problems, whether they're refractive or an IOL exchange or whatever it is, unless you have those tools in your kit, I think it's going to be hard to get traction with these lenses.
Agreed. So one other question I have for you guys is relating to patient education. So we touched on these topics briefly in our first two talks, but is there anything that you're doing in your office that you found particularly valuable? I mean, is there an information sheet you've created? Is there a website you send people to, in-office videos? You know, what are your best ways to educate your patients?
Well, you know, the most important conversation is with the surgeon for sure. And there's no brochure or website that substitutes for that. So that recommendation that we just talked about is important. I think there are a number of good tools for doing this in video. Certainly MD Backline has its own educational material before and after the consult. But, you know, the idea that you raise awareness in as many patients as you can probably is most important, and more important than what platform you use to educate.
I can tell you what does not work. Having tried everything, what does not work is to give the patient 3 different technology alternatives and say, well, do you want this lens A, do you want lens B, or do you want lens C? I think it's our job to solicit what the patient desires, and it's our job to design a surgical solution to fulfill those desires as best we can.
And often I think it's a great point, Steve. It's good to give a patient, I learned this from John Potter, who worked for TLC for years, that it's good to give a patient 2 options, but a recommendation for one of those 2 options with an explanation. That conveys that you have put some thought into it and you really are on their side. And so it's a great point, Stephen. And I think we all can do that.
Yeah, that's just not overwhelmed with choices. And I tell patients, I'm going to confuse you with all these choices, but you're not going to make that choice. I am. You're going to tell me what you want. I'm going to tell you how to get there.
Yeah, it sounds like I need to go to Yuri's clinic more often. Be the boss. I like that. No, but I think that education, you know, when we look at like ways to make the process more efficient, and, you know, there's certainly some patients that want all that information. It's just not practical to give it to them like doctor to patient necessarily. And I think that, you know, drawing on some of the pearls of trusting your staff and relying on your staff to educate your patients, I think is key. I've been using a little bit of the Rendia education just on like broad brushstrokes about cataract surgery, what's femtosecond laser surgery. I think those can be things that, well, pre-COVID, we used to be able to give patients an iPad, but, you know, those are links that you can email out ahead of time. I think that sort of makes the conversation a little more streamlined when the patient has read something before they come to your chair. And so certainly ways to get more information. Well, I want to thank you guys for such a great discussion. We're going to move on to our next set of topics and our next 2 lectures. So we have Dr. Bill Trattler, who is going to be speaking on topography, pearls, and pitfalls. And that will be followed by Dr. Yuri McKee, who will be speaking on corneal wavefront aberrometry. And after that, we will have a panel discussion.
Hi, I'm Bill Trattler from Miami, Florida. I'm very honored to share this talk on topography, pearls, and pitfalls. These are my disclosures. The relevant ones are Oculus, RxSight, and Zeiss. Just 2 pearls to think about. First, consider preoperative topography on all of your cataract patients. One caveat is you cannot charge insurance for screening tests. The second is that topography can actually identify corneal shape irregularities even when the slit lamp exam is on 100% normal. So we'll talk about that more during the talk. Here's a case example, a patient with a visually significant cataract. They have a normal or healthy macular OCT. The slit lamp exam is completely normal, no guttata, no opacities. They have this nice cataract with loss of best corrected visual acuity. And the question is does this patient have a corneal condition that may affect the patient's postoperative vision? And the answer is they may. Unless you perform topography, you may not realize that this patient has early keratoconus because the slit lamp exam will be normal. This patient had mild inferior steepening consistent with mild keratoconus, and likely will have some reduction in their best corrected visual acuity postoperatively. So it's important to identify this during cataract surgery consultations. Now here's a topography of a patient that came in with these areas of red, which are steep, and then other areas where they're flatter. And you can see there's quite a bit of irregularity when you look at this topography. The biometry shows Ks that are 44 and 46 and recommends an 18.5 diopter lens. Well, this patient's irregularity was related to dry eye. We identified the dry eye and treated the dry eye. And the patient came back a month later, and now the shape of the cornea is much better, but not perfect. And you can see that the biometry now found flatter Ks and now recommends a 20.5 diopter lens. So now that we've shifted by just treating this patient's dry eye from an 18.5 diopter lens to a 20.5 diopter lens, you can see that if you had done an 18.5 diopter lens, the patient would have ended up quite hyperopic. So it's important to identify and treat these patients and repeat the biometry prior to cataract surgery. Now, shifting to LASIK, this is an image of two different patients of previous myopic LASIK where the central cornea is flat. You can see the blue is a flatter area, and it's surrounded by this rim of steepness, which is in red. This is very classic images for post-myopic LASIK. Same for PRK or SMILE will have the same type of image. Now the question is, how much astigmatism is typically present after myopic LASIK or PRK or SMILE? And the answer is typically very little, usually less than 1 diopter. So if you see a patient when you're doing a cataract consultation and their astigmatism is greater than a diopter, you should be suspicious of conditions like EBMD, Saltzman's, dry eye, or even keratoconus, or post-LASIK ectasia, all conditions that could cause more astigmatism and need to be identified preoperatively. So this is a patient of mine that I saw. They came in for consultation. You can see there's a patient at previous LASIK, and the flat blue zone is pushed up into the left, and there's an area of steepness in the visual axis. So there's this irregular astigmatism, and the patient's going to actually notice a reduction in best corrected visual acuity following cataract surgery. So it's important that we identify this preoperatively, talk to the patient so they're not surprised after cataract surgery, then they're not seeing as well as hoped. As well, if we look towards what their pupil size is at nighttime, it'll be much larger than the dashed line that you see more centrally here. And so I just try to make an image of what it might be like at nighttime. And now you see there's even more of this irregularity, this steep area that's into this visual axis with a larger pupil size. And so this patient at nighttime is likely going to have even worse quality vision. So again, it's really critical that we discuss this with our patients, talk to them about it, and make sure they're aware prior to cataract surgery. Now, Dr. Lowe, who's a wonderful ophthalmologist in Miami, shared this case with me. This is a patient that had significant astigmatism many years after their previous myopic LASIK. As we mentioned, this amount of astigmatism is a red flag. So the topography revealed that there's this flat blue zone, which we expect to see with myopic LASIK, but then arising from that is this red area, which is a steeper area, and this is consistent with post-LASIK ectasia. And so it's, again, critical to identify this because this patient's best corrected visual acuity will be reduced following cataract surgery. We want to avoid a toric lens here. It's hard to figure out the axis of astigmatism. And also we want to consider a monofocal lens, and may want to consider cross-linking in the future. Now here's an example of a patient with keratoconus. While toric lenses sometimes can be used here, there's no clear axis, so to avoid a toric lens in this type of patient. Now, this is a patient with a pellucid pattern. You can see there's this red horizontal astigmatism, but then it loops around into a crab claw-like pattern. The astigmatism, though, is quite regular centrally, so this patient can actually do quite well with the toric lens because the astigmatism, as I mentioned, right in the middle is quite regular. And so okay for a toric lens. Obviously, we would want to avoid AKs or LRIs in this type of case. Now, here's a patient with 2+ cataracts who has about 1.5 diopters of astigmatism. Again, in correcting astigmatism, we have options of toric lenses or AKs or LRIs. And you look at the astigmatism, at the topography here, you can see that this patient has this, again, this plosive pattern where there's this kind of crab claw appearance. There's also inferior steepening where it's flatter above and steeper below. So you'd want to really avoid AKs typically in this type of case. But surprisingly enough, the surgeon did not recognize that this was, because sometimes it can be difficult, did not recognize this as a occlusive pattern, placed AKs, and this is how the patient looked a month later. See that there was a significant overcorrection. There's now irregular astigmatism vertically with 2.4 diopters of astigmatism. So in this type of case, you want to avoid AKs. This patient could have had a toric lens. You can see that central astigmatism is quite regular, but just avoid AKs in this type of case. So the last case I'm going to share is a patient that had a visually significant cataract and has this irregular astigmatism where there's a little flat area, which is that purple zone, which is flatter due to a little haze of the cornea, but has actually regular astigmatism that's vertical. We looked at the astigmatism topography versus biometry, and there's a little bit of a difference. And we talked about our different options, and we decided that we'd proceed with a light adjustable lens because we could titrate the astigmatism after surgery. So the patient went ahead with the light adjustable lens, started off 20/40 about 5 weeks postoperatively, then had their first treatment, ended up 20/30, a second treatment ended up 20/25, and they got locked in, and then came back 6 months later with 20/25 vision and quite happy. So in summary, consider preoperative topography in all your cataract patients. Abnormal topography can be caused by dry eye, and identify patients with keratoconus pellucid prior to AKs and LRIs. I hope this was a helpful overview. Thank you so much.
Well, hello folks, this is Yuri McKee, and I'm going to talk to you today about corneal wavefront aberrometry for the 20 Happy Masterclass. What do you need to know about higher order aberrations? First of all, you already know something that you might not have known. Higher order aberrations exist and you solve them every day with glasses. This is the Zernike radial order number Z2 for astigmatism, defocus, and prism. So we don't need to go any more into that, you're already an expert. The higher order aberrations I want to talk about today are coma and spherical aberration, Zernike radial order number 3 and 4. There's a huge Zernike tree in front of you. You only have to learn 2 of these to be effective at choosing the right IOL for your patient. Now these higher order aberrations are distortions in the shape of the cornea that are not amenable to correction by glasses or soft contact lenses, but hard contact lenses can cover and solve these problems. If you don't have a topographer that measures higher order aberrations, a rigid gas permeable over-refraction can demonstrate that they were there if the RGP solves the problem. There is significant improvement with the rigid gas permeable lens in the setting of higher order aberrations. This is a pupil size dependent exercise. We typically measure higher order aberrations at 6 millimeters because that is usually the maximum scotopic pupil size. But remember that a smaller pupil size will reduce higher order aberrations. So let's talk about coma first. I'm showing you a topography that shows a small amount of oblique coma. Next to that, you're seeing what a physicist sees when they think about coma. And there you can see what should be a point source of light is skewed in one direction. Now on the bottom, you can see the simulated E with coma showing image duplication and distortion. Generally, about 3/10 of a micron of coma becomes bothersome for patients, and this is my personal cutoff to avoid a multifocal lens. Spherical aberration causes image glow or soft edges. Patients might be 20/20, but they still say the image is blurry. So the topography here is a case of post-myopic LASIK, a flat center causing increased spherical aberration. There are no hard and fast numbers, but typically around 0.4 to 0.5 microns of spherical aberration will be noticed. Myopic LASIK increases spherical aberration. Hyperopic LASIK can cause negative spherical aberration. Many IOLs are designed with negative spherical aberration to counteract the normal positive spherical aberration in the cornea, which is typically around 0.2 to 0.3. So here's a case study of coma. You can see here that the right eye has something, just a bit of irregular astigmatism. The left eye, while having more absolute astigmatism, has regular astigmatism. This patient had a symphony in both eyes. He's very happy with his left eye. He's very unhappy with his right eye. I'll tell you, he has a normal exam with professionally done surgery. But he still complains the right eye is blurry and the left eye is clear, even though on exam they look identical, other than the fact that the posterior capsule is open on one side. Now, the patient is not bothered at all by scotopic rings or halos. Look at the refraction on the bottom of this page. With a slight refraction, he's 20/15 plus, but he's still unhappy. If we look at the corneal wavefront analysis, we can see in the right eye that while neither the vertical or horizontal coma exceeds 0.3 microns, the vector analysis of that comes very close to 0.3 microns. In the left eye, the coma is insignificant. This patient is bothered by the composite coma of the right eye on top of his extended depth of focus lens. If he had additional spherical aberration, this would compound the problem. Here's the image simulation for this patient. The top line shows the 2100E. It's slightly blurry. If we remove the higher order aberrations in the image simulation, the E becomes quite clear. Imagine what he sees on the 2020 line with a multifocal lens. He's very unhappy. We put a rigid Gasparinal lens in this patient, and most of his problems went away. He does have some vitreous floaters and debris, and sometimes we see that as a reason for unhappy patients in multifocal IOLs. But the majority of his complaints were due to the small amount of coma in his cornea. Let's look at a second case. This is spherical aberration. This is a 48-year-old physician. He had ICLs because he was myopic. They caused cataracts. He had cataract surgery with a femtosecond laser and arcuate keratotomies. He's been not happy with his vision since the day after surgery. Everything he says is soft and glowing, and there are dark arcs temporally in both eyes. So he has negative dysphotopsia, but there's more to it than that. His entire exam is normal except the topography, which I've included a picture of, and you can see that the corneal topography is rather irregular. The posterior capsule in the right eye is open, and he has a slight PCO in the left eye. YAG laser capsulotomy did not help him. Look at the spherical aberration. It's 0.383. His manifest refraction gives him 20/15 plus vision, but he still says it's blurry. What happened here is the patient had an SA60AT lens with approximately 0.18 microns of spherical aberration, which was added to the 0.38 he already had. His total spherical aberration is around a half a micron, and he notices it. The negative dysphotopsia doesn't help at all. His IOL was exchanged for an LI61AO with reverse optic capture. This solved the negative dysphotopsia, and the zero spherical aberration IOL solved his blurry, fuzzy 20/20 vision. He was very happy. Due to the COVID-19 pandemic, the second eye surgery was delayed until just recently. I will note I didn't do this surgery because my surgery center was not ready to do surgery, and the COVID-19 pandemic prevented us from scheduling promptly. He went to an excellent surgeon in Los Angeles who did a beautiful job with this surgery. So use caution with your IOL selection. I've seen many patients in the last several years come in for a second opinion of poor quality vision because they had an SA60AT IOL placed and they had higher corneal spherical aberration to start with. So a better choice in post-myopic LASIK eyes or eyes with high spherical aberration would be an SN60WF or a ZC-BOO, which both have negative spherical aberration. The B&L MX60 has zero spherical aberration. It's a very good choice for normal corneas because you get a better depth of focus and generally good vision quality. The SA60AT should only be considered in cases of hyperopic LASIK, in my opinion. So in conclusion, if you only know two higher order aberrations, no coma and no spherical aberration, don't use multifocal IOLs when you see coma exceeding 0.3 microns. Consider both components of coma. Consider the spherical aberration. Don't worsen positive spherical aberration with the wrong IOL. Use a negative spherical aberration IOL in post-LASIK eyes and a zero spherical aberration IOL in cases of low corneal spherical aberration or in hyperopic LASIK. If you never look, you'll never find the higher order aberrations that can destroy your 20 happy result. Thank you very much.
All right, Bill, Yuri, excellent talks. We're going to have a panel discussion now. And in our panel, we have Bill Trattler, Yuri McKee, Ed Holland, and Ned Ishami. So I thought I'd start out with a question for Bill Trattler. You made the point that keratoconus and irregular astigmatism are obviously present in some of our cataract age patients. And there's this conventional wisdom that if you see a patient with keratoconus who's now in the cataract age group, you don't need to worry about that ectasia or that keratoconus progressing. And so a lot of people don't cross-link these patients prior to cataract surgery. What are your thoughts about that?
Well, Stephen, great topic. You're absolutely right. Patients, we find these patients all the time. They have no history. They never knew they had keratoconus. they're not seeing well, and they somehow have either a pellucid pattern or early keratoconus, and they come to us for they have cataracts and this finding. My recommendation typically is if the cataract is significant, do cataract surgery first, explain to the patient they'll need cross-linking at some point down the road, and then down the road, whether it's 2 months, 4 months, 6 months, we'll then address the cross-linking to stabilize things. You're going to get a big bang by doing the cataract surgery. They're going to be confident in you. You've made them see a lot better. And now you can start addressing the second part, which is keratoconus or pellucid. So that's been my strategy. If it's a very minimal cataract, you could do cross-linking first, but I typically do cataract surgery first.
You know, Steve, I think the key is to see if the cornea is stable. Has it auto cross-linked over the years? And so what we like to do is get serial topography on these patients or obtain old records to make sure. You know, as Bill said, he had some beautiful, examples. Mild to moderate keratoconus can be managed with toric lenses if the corneal topography is stable.
I think if I can comment on that too. First of all, great talks. I'm really enjoying this, learning a lot myself. So what a pleasure to be here. Thank you for having me. In patients who have comorbidities like a corneal condition such as keratoconus or Fuchs, as well as cataracts, I think one of the challenges is to really try to determine which one is contributing to their visual deterioration. And as Ed was saying, I think getting history is really critical. I often, and these patients, it's not just their historical reflection of their vision deterioration, but also getting, doing a chart biopsy and looking at their corneal topographies, for example, or the refraction. If the refraction or the cylinder hasn't changed, but their vision has deteriorated, you can point at potentially the cataract being the main problem. And in those patients, you hope that their keratoconus is stable and you can forge ahead with more confidence. But it's tough in those who don't have history, or they say, this is the first time I'm being told I have keratoconus. That's when I think the route that Bill was mentioning, going ahead with cataract, giving them the wow of cataract, but maybe making sure educate them about the progressive nature of their corneal condition.
So Bill, you pointed out a case where a surgeon did not recognize ectatic disease and performed femtoarcuates, which is definitely going to cause some trouble. But I've seen and reported on a number of very normal corneas that had femtoarcuate incisions placed that developed ectatic disease. And it typically occurred in the horizontal meridian. I'm wondering if you've seen that as well in totally normal topographies preoperatively. You're muted, Bill, but if you, yeah.
Can you just say the question one more time? I got lost for a second.
Okay, so you pointed out some patients who had ectatic corneas that were missed and had femtoarcuates placed, which is obviously a problem. But I've also seen some femtoarcuates cause ectasia in totally normal looking corneas with normal topography. So I'm wondering if you've seen that or anyone else in the panel has seen that.
Well, I've seen that reported. I haven't seen the preoperative topographies. I've heard about it and seen the cases after, but I haven't had a chance to review the cases, what they look like ahead of time.
Steve, if I could comment on that. If I'm going to do any type of incisional refractive, I'm going to look at a Pentacam, for example, look at the Bell and Ambrosia display. If I wouldn't do LASIK on someone, I wouldn't do femtoarcuates on someone. Sometimes the can look fairly normal on a standard Placido topography, but the Pentacam, a bad display, can show you something else. So that's one thing. And the other thing is toric lenses well. And if someone falls into the candidacy for a toric lens, that's what I'm going to do for them. I'm not going to give them arcuates because they don't want to pay extra for the toric or something like that. If they don't fall in the candidate for a toric, but still have a little bit of astigmatism I want to treat, that's where I start using small arcs. So I think the key is screening with tomography and topography, arcs small and leaning toward torics when you can.
Yuri, I loved how you pointed out the influence of coma and how significant that can be. Would you like to comment on the influence of ocular surface disease on coma itself, and sometimes how you can really change the higher order aberrations by treating ocular surface disease?
Oh, absolutely. That's a huge key. As a matter of fact, I've stopped looking altogether at these factors when I first meet someone. What I do instead is I tell people this decision to have surgery is going to affect you every waking moment for the rest of your life. Whatever lens we put in your eye, you're going to know it for the rest of your life. So what I want you to do is think about the things we've talked about today. Go home, do this tear tune-up film or tear film tune-up program that I give to every patient. In 2 weeks, we'll do your real measurements, and then we'll talk about what you're a good candidate for. So I just stopped even caring what the high order aberrations look like the first time I meet someone.
You know, Steve, the number one cause of unhappy, I'd say, premium IOL patients is not the fact that the surgeon missed the refractive target. It's certainly ocular surface disease. And what often happens is the surgeon really misdiagnosed mild to moderate dry eye, or subtle other epithelial problems like epithelial-based membrane degeneration, which we'll talk about in the next section. And, you know, I want to make sure that the cornea is absolutely normal before we go into surgery. And often if these patients have significant dry eye, as Yuri said, we want to manage those pre-op, you know, and potentially delay the surgery. And if we can't get the epithelium normal, I certainly don't recommend a multifocal IOL.
Well, that's a great segue into our next section here. So we have 3 talks coming up. The first one is Ocular Surface Evaluation and Tune-Up by Priya Gupta. And then we'll talk about corneal pitfalls with you, Ed. And then we have IOL Selection for Post-Refractive Eyes by Nedashami. So we'll segue into those talks now. Thanks.
Thank you.
Hi, this is Dr. Priya Gupta, and today we are going to be talking about how to do an ocular surface evaluation and tune-up and what my top pearls are to make this successful. These are my financial disclosures. So, pearl number 1, make the diagnosis of ocular surface disease before surgery. And the reason why this is really important is that OSD can really have a negative impact on cataract and refractive patients in terms of their vision quality being subpar. We know from studies that patients, even though they see 20/20, if they have dry eye, they're unhappy with their quality of vision. You can have refractive surprises, and we know this because hyperosmolarity has been found to actually lead to variability in keratometry. And last but certainly not least, we all are very familiar with our patients who actually describe discomfort postoperatively when their eyes are dry. Dr. Chris Starr and I did a study which was published in 2018 that assessed the prevalence of OSD in cataract patients. And shockingly, what we found was that 80% of the patients that presented in our study, and these were patients presenting for routine cataract evaluation, 80% of those patients had at least one abnormal test or corneal staining suggestive of dry eye disease. And when you really look at this, when we see patients in our practice, if we're not looking for ocular surface disease, we're actually likely going to be missing it because so many patients present with this finding. Interestingly, in our study, we found that in the patients that were asymptomatic, so they all got questionnaires, and the asymptomatic group, which was about half of the study population, 85% of those patients were found to be asymptomatic and had an abnormal point of care test. So we know that if we can incorporate point of care testing, that we're actually going to do a better job of finding these patients. Pearl number 2, use point of care testing to help make the diagnosis of OSD. The TFOS JUICE 2 updated definition really encompasses a lot of aspects, but the key 2 key words here for me are hyperosmolarity and inflammation. And as such, I use those 2 tests to help guide how I assess dry eye disease. Osmolarity is a point of care test readily available, and if it's found to be abnormal, is highly characteristic of dry eye. MMP9 is a non-specific marker of inflammation. And so this test is actually just, again, a point of care test where you absorb some of the tear meniscus, and it will tell you whether or not a high level of MMP9 is present. I think point of care testing is very helpful because it can be it can add another layer of efficiency to how you diagnose dry eye. It can largely be performed by technicians in your clinic. And for the clinician, you really your job is to interpret everything that's being gathered, so it doesn't take more time for you. I think it can also be helpful to identify non-dry eye disease related ocular surface dysfunction. And last but not least, I think it's a more effective way of screening patients rather than relying primarily on questionnaires or eliciting symptoms. Pearl 3, when trying to diagnose OSD, use an algorithm. The ASCRS Cornea Clinical Committee put together an algorithm that really helps clinicians kind of work through how to efficiently and effectively diagnose OSD. Patients would undergo a screen, and that includes assessment of symptoms using ASCRS Speed 2 questionnaire, and then assessing signs, which we felt most importantly were osmolarity and MMP9. But if you don't have access to those tests, you still can screen patients for dry eye disease. Probably the most important aspect of this algorithm, I think, is doing a targeted clinical exam. We coined the mnemonic LLPP to help clinicians remember to look for all of the important aspects of OSD. So look at the lids, look at how the patient blinks, lift the upper lid. A lot of corneal pathology like ABMD and Salzmann's nodules can be found there. Pull, looking for lid laxity, and last but certainly not least, pushing along the meibomian glands to assess the quality of the oil, as we know MGD is a major contributor to dry eye. Stains such as fluorescein and lissamine green can be used to assess the corneal surface, which is very important because we want that corneal surface to be pristine prior to surgery. If the patients failed their OSD screen in any way, so they have symptoms or they have signs, then that's considered visually significant OSD, and it really behooves the clinician to aggressively treat that to avoid some of these issues that we're talking about related to surgery. Number 4. Treating OSD does not have to be hard preoperatively. So I like to divide my treatments kind of into 3 broad categories: over-the-counter treatments, topical prescription therapies, and then what I call disease-modifying procedures, but really these are mostly MGD procedures. The 3 major anti-inflammatory molecules out there, so there's cyclosporin, 0.05%. There's also a newer addition, Cequa, which is a nanoparticle of cyclosporin. Lifitegrast, 5%, or Xiidra, which is an LFA antagonist, which has been approved to treat the signs and symptoms of dry eye disease. And then, of course, last but certainly not least, topical steroids are very important in rapid rehabilitation. When I look at kind of the 2 parts of dry eye disease, I look at treating inflammation and I look at treating MGD. And when I think about how I prescribe these medications to patients, I like to often start with a topical steroid. And then for patients that I think that are high risk for chronic symptoms or might have chronic dry eye disease, I also typically add lifitegrast, because in their FDA trials, it worked as early as 2 weeks in 2 out of their 4 studies. With respect to the MGD treatments, I think treating MGD is paramount to really have a healthy tear film. And it's because the oil really protects the surface and prevents evaporation. The key principle is that we have to relieve the obstruction. There's a lot of treatments that are out there today. There's LipiFlow thermal pulsation, which has a lot of evidence in the literature. It's been around, the longest. TearCare and iLux are newer to the market, but have excellent efficacy in treating MGD. And then other treatments, which I don't typically use in my pre-op patients, but IPL and Blefex with expression. So in summary, these are my 4 pearls. Diagnose OSD before surgery. Use point-of-care testing to identify OSD pre-op. Use an algorithm to help you kind of navigate the system of diagnosing OSD. And treating OSD in a rapid and effective manner is really the linchpin approach to treating these patients before surgery. Thanks so much.
Hi, I'm Edward Holland. I want to talk about corneal disease in your cataract patients. These are my financial disclosures. Corneal disease is really common in your cataract patients, and some of the key concepts to consider when evaluating the cornea: what's the severity of the condition? What's the likelihood of progression? Will you be considering a premium IOL? The decision to treat will be based on whether the condition affects the preoperative calculations or reduce the postoperative vision. And then finally, the timing of the corneal treatment if you decide to treat. Should it be before the cataract surgery, combined with the cataract surgery, or after the cataract surgery? Corneal conditions are very, very common in this patient population, and we can talk about dry eye disease, corneal degenerations, and corneal dystrophy, specifically Fuchs dystrophy. And we know that dry eye is extremely common and can affect the accuracy of your preoperative measurements and lead to inaccurate calculations and IOL choice. And we know that all the innovations in our new technology can be lost with a poor tear film and a poor epithelial layer. Cataract patients' main complaint of dissatisfaction with the results are based on dry eye more than any other condition. We do have strategies to reverse dry eye in your surgical patients. We can use pulse therapy with topical corticosteroids. We can use punctal occlusion. We can use devices such as microblepharoexfoliation and thermal pulsation for MGD. We want to initiate and maintain patients on therapy who have significant dry eye, such as omega-3s and the other anti-inflammatories besides steroids. But I want to point out you should consider delaying surgery if there's significant epithelial disease as signified by corneal staining, especially if you're using a premium IOL. What about the degenerations? Well, epithelial basement membrane degeneration is extremely common. It can be subtle with microcysts and small ridges or lines, or it can be obvious with macrocysts and big maps, but it's often missed unless you do this broad oblique illumination, as you can see in the lower right-hand corner. How do we treat it? Well, if there's significant EBMD with no scarring, a superficial keratectomy alone may be the treatment of choice. If we do see scarring, then we want to add PTK to remove the scarring. One trick that you should remember in the operating room for localized poor adherent epithelium is anterior stromal puncture. This will prevent a large epithelial defect and the patient's symptom postoperatively, and it's very easy to do. What about Salzmann's nodular degeneration? Again, very, very common. The findings can be quite obvious as the slide on the top with large white dense nodules, or can be much more subtle and sometimes really low sheets of subepithelial scarring that can be missed. The treatment is, if it's a nodule that can be removed by excision with superficial keratectomy, that's what we do. If there's a lot of scarring, then we'll add PTK. If these nodules are toward the visual axis and affect your preoperative calculations and give a regular astigmatism, they should be managed before surgery. Pterygium, very common. We think about excision if the pterygium affects the visual axis or induces a large amount of astigmatism. And then with any premium IOL, I would like the pterygium removed because of change in the cornea that can be affected and the potential progression of the pterygium. What about keratoconus? One rule is avoid incisional surgery in the cornea for keratoconus. It's very unpredictable, the outcomes, and can lead to a very, very poor result. Toric IOLs are okay if we know the cornea is stable. If the patient's older and we have serial stable topographies, even though the astigmatism is irregular and asymmetric, they can benefit from toric IOLs. Corneal dystrophies, there's many corneal dystrophies, and I alert you to the IC3D classification. And any of these dystrophies can disrupt the visual outcome, and I'd be cautious about a premium IOL. But let's talk about Fuchs dystrophy, the one that you see the most often. Patient history is important. A blurred vision in the morning is a sign of corneal decompensation. Endothelial cell count alone does not dictate whether the patient gets an EK or not. We can have confluent gutata centrally, and can't really get a cell count there, and the patient has no stromal edema, and I'll do phaco alone. Pachymetry really is a guide. If there's a change in pachymetry to a late afternoon to a morning appointment of greater than 10%, that can be a sign of corneal decompensation. But really, we use a slit lamp and the finding of stromal folds and stromal haze and epithelial edema to document corneal decompensation. So guidelines for the Fuchs patients with cataract: if there's stromal edema with any level of cataract, or if the patient's presbyopic, a phaco-EK is the treatment of choice. If the patient has stromal edema but no cataract and is pre-presbyopic, then EK alone is indicated. And that patient with confluent gutata but no edema, I think phaco alone is a very reasonable choice with the discussion of with the patient about the potential for corneal decompensation in the future.